My name is Ajay Nooka. I'm an associate professor at the Winship Cancer Institute of Emory University. I'd be discussing about the therapeutic outcome differences in myeloma and the precursor lesions by race. The incidence of plasma cell dyscrasias, including the precursor lesions of monoclonal gammopathy of undetermined significance, or MGUS, and smoldering multiple myeloma, as well as multiple myeloma, are 2 times higher in blacks compared to the whites. The presentation at the time when the diagnosis happens in the blacks is way earlier, almost 5 years younger compared to the whites. These raise the question of the biological and the genetic differences by race. As we had seen over the last 2 decades, the treatment with novel agents and the use of transplant has become a standard of care for the newly diagnosed multiple myeloma patient. However, the racial and the ethnic minorities receive these treatments at a much lower rate than the whites. Evidence suggests that the Black patients with myeloma have the potential to experience similar or better survival than the white patients with multiple myeloma. This is corroborated by the fact that the Black patients have similar response rates and survival when enrolled in the clinical trials compared to the white patients. There are race-dependent differences in the risk of transformation to clinical myeloma among the patients with the precursor lesions. One of my colleagues, Dr. Madhav Dadapkar, led a SWOG study, the SWOG S0120, which is a US cooperative group prospective observational clinical trial evaluating the natural history of the precursor lesions of MGUS and the smoldering multiple myeloma. Interestingly, what has been shown was the Blacks had significantly lesser risk of transformation to clinical multiple myeloma, presented as a 24-month estimate of 5% in the Blacks compared to other races where the same estimate of 24 months is 15%, owing to several biological hypotheses. Moving on to looking at the interventions in this high-risk smoldering multiple myeloma space, there was another clinical trial that was ECOG run. This is the Eastern Cooperative Group run, evaluating the intervention of using lenalidomide, which is an immunomodulatory agent, as an intervention among the patients with high-risk multiple myeloma to prevent the progression to symptomatic multiple myeloma. This was a phase 3 randomized trial, and a total of 182 patients were randomized to receive lenalidomide in 90 of them and observation in 92 patients. The median age of the patients was 64 years, and approximately 17.9% of this total population was Black. If you look at the progression-free survival of lenalidomide versus observation across all the subgroups of the patients that were tested, every subgroup got benefited with the intervention of lenalidomide to prevent the progression to symptomatic multiple myeloma. For example, patients less than the age of 70 had a hazards ratio of 0.37, in essence, a 63% reduction in the risk of progression to multiple myeloma. Similar rates were seen in patients above the age of 70, where the hazards ratio was 0.13, which is an 87% reduction in the risk of progression to multiple myeloma. The only group across that has not seen the same kind of a benefit is the Black patients, where the hazards ratio was 1.73. Of course, the confidence intervals are much larger, between 0.1 to 30, and the hazards ratio of 1.73. This is the only group that did not get the benefit from an early intervention, such as lenalidomide, among this patient population. However, among whites, the hazards ratio is 0.22, which is a 88% reduction in the risk of progression, raising the possibility of a therapeutic differential in this case. Moving to the newly diagnosed setting. 5 years ago, there was a retrospective analysis that was put in from the Baltimore group, where they looked at the induction responses with novel agents among the African Americans versus the whites in this specific paper. A total of 453 patients were evaluated, and 279 patients were white, and 174 patients were Black. The VGPR rates were much lesser in the Black patient population at 11%, and the white patient population was 21%. And the patients that received the immunomodulatory agents among the Blacks had a 25% greater than VGPR response rates, and the patients that received immunomodulator-based therapies among whites had a VGPR rates of 32%. If you look closely among the responses in the whites, the IMiDs plus the proteasome inhibitors resulted in an odds ratio of 2.3 compared to the same IMiDs plus PIs in the African Americans with an odds ratio of 1.5, whereas among the PIs, you see the same odds ratios of 3.7 and 3.8, suggesting that Blacks may not be getting the same kind of a response as the whites with the immunomodulatory agents and the PIs. If you look at the COMPASS trial, there are significant genetic differences as well as the outcomes, and these are treatment dependent as well by race. Similar to what has been alluded to before, the Blacks presented much younger than the Caucasians in the COMPASS trial, which is a longitudinal observational trial across the entire United States among 1,000 patients. And the IS stage was not as different. And when you look closely with the differences among the patients that received a IMiD plus a PI, the Caucasians got a better benefit than the Blacks. Moving to our institutional aspect of using this three-drug combination among 1,000 patients, what we were able to show over the last decade was a significant benefit in terms of the PFS. The median PFS among all the patients that have received this three-drug regimen in 1,000 patients at our university was 65 months. If you look at the overall survival among the same patient population, it is beyond the 10-year benchmark, forming a new benchmark for survival outcomes among the patients diagnosed in the new era. If you look by the outcomes by the race, the median PFS among the high-risk patients was 40 months. The median PFS in the standard risk patients was 76 months. And similarly, the median overall survival for the standard risk patients was not reached, whereas the median overall survival for the high-risk patients was 78 months. Now, we'll look closely at differences by race in terms of the characteristics as well as the therapeutic differences. As had been alluded to multiple times previously, the Caucasians presented at an average age of 62 years, and the Blacks had an average age of presentation of 57 years, which is a 5-year younger presentation at the time of the diagnosis. Interestingly, the median BMI was higher in the Blacks at 29.4. Similarly, the median BMI was greater than 40, was higher in 7.9% versus 4.2% in Blacks versus the whites. Black patients had the median baseline hemoglobin to be lesser at 10.1 compared to 10.9 in the whites, all these reflecting the baseline characteristic differences by the race, which are statistically significant. Looking at the cytogenetic differences, there are clear differences in terms of the genetics among these 1,000 patients, which consisted of 619 Caucasians and 352 African American or Black patients. The rates of 1Q gains are much significantly higher among the whites at 18.8% versus the Blacks at 10.8%. Rates of translocation 11-14 were much higher in the Black patients at 16% versus 11.5% in the whites, raising a possibility that African Americans have higher rates of translocation 11-14, which could be leveraged using a targeted therapy such as venetoclax. The rates of deletion 17p, which is a high-risk genetic abnormality, was much higher in the whites at 12.1%, and in the blacks, it was 6.7%. Now, looking at giving an equal access to the initial 3-drug regimen with RVD, initial access to a transplant, the progression-free survival as well as the overall survival were almost equivalent across these two groups of the whites and the blacks. Now, moving forward, we know that we were able to achieve with equal access and with equal access to the novel agents as well as the transplant, we were able to gain a good equivalent survival outcomes across both groups. Now, how about the addition of the passive immunotherapy with a naked antibody like daratumumab? The Griffin trial randomized patients to receive RVD versus daratumumab plus RVD, daratumumab being a CD38 monoclonal antibody. This is a randomized phase 2 trial across 35 sites in the United States, enrolled between December of 2016 to April of 2018. Patients would receive a transplant after 4 cycles, and the daratumumab arm would receive 2 further cycles of daratumumab plus RVD, followed by daratumumab plus lenalidomide maintenance from cycle 7 to 32, altogether for a period of 36 months. The lenalidomide arm would get RVD for 4 cycles, followed by a transplant, followed by RVD consolidation for 2 further cycles, followed by lenalidomide maintenance for a total of 3 years. The primary endpoint in this trial is a stringent complete response rate by the end of the consolidation after cycle number 6. If you look carefully at the RVD that was received by the whites or the blacks, it was 33%. And if you look closely at the patients that received daratumumab, blacks seem to have a much better or a bigger benefit compared to the whites. By the addition of daratumumab resulted in a stringent complete remission rate of 43% in the whites compared to 71% in the black patient population. Even though this was a small subgroup of patients, the overall response rate, the rate of complete remissions, rate of VGPRs were all improved with daratumumab plus RVD versus RVD in the black patients, the magnitude being much higher compared to the white patients. The most common hematological toxicities that occurred in more than 30% of grade 3 or 4 treatment emergent adverse events for daratumumab plus RVD in the black patients were almost similar to what you see in the white patients as well. Slightly pronounced neutropenia of 50% of grade 3 and 4 compared to 41% in the whites. Again, slightly pronounced anemia of grade 3-4 in 14% in the blacks versus 8% in the whites. Similar rates were seen for thrombocytopenia, which was more pronounced in the blacks at 29% versus 15% in the whites. The higher rates of grade 3 neutropenia, leukopenia, and thrombocytopenia were seen among patients that received the daratumumab combination in the black and white subgroups, more prominently in the black groups. So, in Griffin trial, the daratumumab versus RVD as induction and consolidation therapy improved the depths of response, including the rates of stringent complete remissions as well as MRD negativity in black patients with newly diagnosed multiple myeloma. And daratumumab plus lenalidomide maintenance, the data that has not been shown here, has further improved the depths of responses as has been recently reported. These results support daratumumab plus RVD as a potential new standard of care for black patients with transplant-eligible newly diagnosed multiple myeloma, but much larger studies are needed to better define the magnitude of the daratumumab benefit in the black patients. Again, the safety profile of the daratumumab combination in black patients was almost consistent with what we saw in the white patients. Moving to another form of immune therapy, the chimeric antigen receptor T cell therapy or the CAR T therapy, we looked at an institutional study looking at the outcomes in the differential toxicities by the race among the first 40 patients that underwent CAR-T at Emory University. The median age of diagnosis is much younger among the Black patients that received the CAR-T. It was 5 years younger than the Caucasians. And the median CAR-T target dose was 300 million cells. And median baseline ferritin in the whites is much higher than the Blacks. And median baseline fibrinogen was much higher in the whites than the Blacks. And median baseline D-dimer is much higher as well. If you look at the outcomes, the median hospitalization across both groups was exactly similar at 14 days. And the any grade toxicity of cytokine release syndrome was much higher at 82.6% in the Caucasians versus 53.8% in the Blacks. If you specifically look at the grade 2 or higher CRS toxicity, this was again higher in the Caucasians at 39.1% versus 23.1% in the Blacks. Even though this was not statistically significant, there's a huge numerical difference by the rate of grade 2 CRS. There was difference in the median CRS duration, which is 3 days versus 2 days in the whites versus Blacks. Similar signal was seen in the neurotoxicity of any grade, which was much higher in the whites at 34.8% versus Blacks at 15.4%. And again, grade 2 neurotoxicity was much higher at 17.4% in the whites versus 7.7% in the Blacks. The median neurotoxicity duration was 5 days in the whites versus 13 days in the Blacks. The overall response rates were 77.3% in the whites versus 84.6% in the Blacks. Greater than VGPR rates were similar across both arms, and the CR rates were almost similar across both arms. What is more interesting was the median PFS numerically favored the Black patients, with a median PFS of 18.5 months among all these patients that received the CAR-T for the Black patients, versus the whites receiving only 8.2 months of median PFS benefit. The median overall survival, again, numerically favored the Black patients, which was not reached, with a follow-up of 21 months compared to the Caucasians or the whites receiving a median overall survival of 21 months. To conclude, the biology of myeloma is likely very different based on the race, and this may explain some of the differences in the frequency of plasma cell dyscrasias being higher in the Black population. Race-related differences in outcomes do exist. However, it is extremely unclear whether it is related to access versus related to the biology. Specific trial and tissue analysis based on the race are extremely critical to understanding how to optimize better treatment for all patients and specifically understand more about these therapeutic differences by the race. Thank you.